Hello friends, welcome back to my channel. In this video, we are going to talk about genitourinary tuberculosis. Genitourinary tuberculosis. This is a very commonly asked question as a short note, both in the undergraduate and the postgraduate exams. So let us know about the genitourinary tuberculosis. The genitourinary tuberculosis is the second most common site of extrapulmonary tuberculosis. This is the second most common site of extrapulmonary tuberculosis. Right, the most common site being the lymph nodes, and the lymph nodes are followed by genitourinary tuberculosis. So the second most common site of extrapulmonary tuberculosis is genitourinary tuberculosis. This is usually a disease commonly seen in adults. Children are usually not affected. The genitourinary tuberculosis, the GUTB, is commonly not seen in children. They are not seen in children. They are usually a disease of the adults. Now let us talk about the clinical features. The most common clinical feature of genitourinary tuberculosis is increased in frequency of the urine. Increased in frequency of the urine. Increase in frequency of the urine. As a whole, storage symptoms are more common. As a whole, storage symptoms are more common. Other symptoms may include hematuria. Dysuria. The most common symptom being frequency of urine. As a whole, storage symptoms are common. Other symptoms include hematuria and dysuria. Now, how does this tubercle bacilli enter the genitourinary system? How does this tubercle bacilli enter the genitourinary system? So, if we talk about the route of spread of infection, the bacilli enter the genitourinary system. The most common route of spread of infection is the hematogenous route. The most common is the hematogenous route. This is the most common route. This is followed by ascending route. Right, ascending route, and this is followed by direct spread. This is followed by direct or contiguous spread. So, second most common cause of extrapulmonary tuberculosis is the genitourinary tuberculosis. This is commonly seen in adults. The most common symptom is increased frequency of urine, and the most common route of spread of bacilli is hematogenous route. Let us move ahead and talk about what are the different changes which occurs in the kidneys, in the urinary system, and what are the different manifestations of the genitourinary tuberculosis. If we talk about kidneys, the tubercle bacilli, where they deposit in the bacilli, they deposit in the periglomerular capillaries. Periglomerular capillaries, a very important question. Where do the tubercular bacilli deposit? They deposit in the periglomerular capillaries. All right. Now they deposit in the periglomerular capillaries. Once they deposit there, what they will lead to? They will lead to interstitial nephritis. They will lead to interstitial nephritis. And there will be formation of granuloma. And this, we know the tubercle granuloma are cause caseous necrosis. So there will be caseous necrosis of the renal tissue. So the tubercle bacilli, after it lodges in the periglomerular capillaries, it will cause interstitial nephritis, and that will lead to granuloma formation. The granuloma leads to caseous necrosis at the center, and this caseous necrosis will damage the renal tissues. This can progress to fibrosis. Any chronic granuloma inflammation may lead to fibrosis of the tissue, and here even this may lead to autonephrectomy. This may even lead to autonephrectomy, which is seen in about 33% of the patients with genitourinary tuberculosis. So the patient ultimately goes to end-stage renal disease. All right. So these are the changes which occurs in the kidneys. Now let us talk about what occurs in the ureters. If we talk about the ureters, the most common site of involvement of the ureters, is the vesico-ureteric junction. All right. From there, the ureter, it can even spread to the entire ureter. Once the entire ureter is involved, this leads to fibrosis and stricture in the entire length of the ureter, and this is known as pan-ureteric stricture. Pan-ureteric structure which gives a beaded corkscrew appearance. Beaded corkscrew appearance. Alright, so the most common site is the vesiculatory junction and it may involve the entire ureter. Then it leads to structure of the entire ureter or corkscrew appearance. This corkscrew appearance is seen in IVP. If we do an IVP, we get to see corkscrew appearance. Alright, now let us talk about what happens in the bladder. It starts at the ureteric orifices. So the first thing to be involved in the bladder are the ureteric orifices. But overall, if we talk about the bladder, the most common site of involvement of the bladder is the dome of the bladder. First site involvement is the ureteric orifices. The most common site of involvement are the dome of the bladder. Now we can remember this way that just like the apices of the lung are involved in pulmonary tuberculosis, similarly the upper part of the bladder are involved in genitourinary tuberculosis. So the dome of the bladder is involved, most common site. It is said that the trigone and the neck of the bladder are usually spared. The trigone and the neck of the bladder are usually spared in genitourinary tuberculosis. Let us move ahead and talk about what happens in the genital system. Let us talk about the genital system. That's about the urinary system. We spoke about the kidneys, ureters, and the bladder. Now we'll talk about the genital system. We'll talk about what are the changes we see in the epididymis. Now see, the most common site, let us understand one thing. The most common site in the genitourinary tuberculosis, the most common organ involvement is the kidneys. The most common site of involvement is the kidneys. The second most common site after the kidneys is the epididymis. It is the second most common site of involvement in the genitourinary tuberculosis after the kidneys. Usually the involvement of the epididymis occurs in the tail of the epididymis. It's usually the tail of the epididymis which is involved. That is the cauda epididymis. It is usually involved because it is highly vascular. That is why the tail of the epididymis is commonly involved. Now, involvement of the tail of the epididymis. Since the epididymis is present in the posterior aspect of the testis, the epididymis is present in the posterior aspect of the testis. Therefore, this might ulcerate via the skin on the posterior scrotum, via posterior scrotal skin. So what do we get? We get posterior scrotal ulcers. So in tuberculosis, the ulcers are commonly found in the posterior aspect of the scrotum. So we find posterior scrotal ulcers. So this is what happens with the epididymis. Now these testes are usually not involved commonly, very rarely involved, and they are not involved primarily. The involvement of the testes is usually secondary to involvement of the epididymis. The testes are usually not involved primarily, they're usually involved secondary to involvement of epididymis. If we talk about involvement, what happens to the penis? There is very aggressive infection leading to rapid necrosis of the organ, So these are the changes we see in the genital system. Now let us talk about how do we diagnose a case of genitourinary tuberculosis. To confirm a case of genitourinary tuberculosis, all that we need to do is the gold standard test is AFP urine culture and detect the tubercle bacilli in the urine culture. Alright, detect the tubercle bacilli in the urine culture. We get a urine culture. Now the criteria for the urine culture is it is usually the early morning sample are taken. The first sample should not be discarded. It is the first sample of the urine that should be taken for testing. So the early morning sample and minimum 3 days, three consecutive sample, or preferably 5 samples. The 3 to 5 days sample should be taken. Every morning sample should be tested and 3 consecutive sample minimum, preferably 5 samples should be tested for urine culture. And this is the gold standard. This is the gold standard test. The gold standard test for detecting genitourinary tuberculosis is the AFB urine culture. Now see, the AFB urine culture, the different culture media are available. The most common media which was used till now, the most common media was LJ media, Lowenstein Jensen media. But this media takes usually 4 to 6 weeks to give a positive urine culture. This usually takes 4 to 6 weeks for the bacilli to give a positive culture. So Bactec medium was used. The Bactec medium was used. This Bactec medium provides results within 10 days. All right. Then even if we want even earlier than Bactec, if we want even earlier than Bactec, we can use nucleic acid amplification test PCR, which gives results in 1 to 2 days. Which gives result in 1 to 2 days. Now, if we want result within hours, we can use Gene Expert. Here we study the gene of the Mycobacterium tuberculosis, and it can give result within 2 hours. We can support this with screening tests. We can there are some screening tests. I'll clear this. There are some screening tests for uh, Mycobacterium tuberculosis, and these screening tests are known as Mantoux test or tuberculin test. Mantoux test or tuberculin test. This tuberculin is injected. Now, depending on the size of the induration, for a general population, if it is 15 millimeter or more, we say it's a positive test. But in case of certain group of patients, especially we call them high risk patients, even a 5 millimeter or more, even a 5 millimeter or more can be considered positive. Who are these high risk patients? We call this by the mnemonic HRCT. H for HIV positive patients, R for recent contact with pulmonary tuberculosis, C for chest X-ray showing features of pulmonary tuberculosis, and T for transplant recipients. If the patient is a transplant recipient. The diagnosis can also be supported by image findings. Let us talk about the role of imaging in genitourinary tuberculosis. Role of imaging in genitourinary tuberculosis. To detect early tubercular changes, to detect the changes, early tubercular changes, the best investigation, the best imaging is IVP. The best imaging is IVP. To detect late tubercular changes or overall investigation of choice is contrast enhanced CCT, is CCT KUB. So to detect early changes, we do an IVP. To detect the late changes or overall investigation of choice is CCT KUB. Now, what are the IVP findings? What are the IVP findings in genitourinary tuberculosis? Let us understand this. Let us understand how the calyces are arranged. Suppose these are upper pole calyces, these are middle pole calyces, and these are lower pole calyces. Now let us assume that the lower pole calyces have been infected with tuberculosis. The first thing that occurs is because of the inflammation. What will happen if these are the calyces? Because of the inflammation, there will be this calyces will become ill-defined. The calyces will become very ill-defined. Now, what will happen? This will lead to the appearance called fuzzy calyx. Fuzzy calyx. So the earliest change is fuzzy calyx. Why the fuzzy calyx is in? Because of the inflammation, the calyces become less prominent. Now, what happens if this inflammation persists? If this inflammation persists, what will happen? We'll get to see parts of the calyces will appear to be eaten up, and this gives the appearance. This gives the appearance which is known as moth-eaten appearance. Moth-eaten appearance. Now, this fibrosis, the persistence fibrosis will lead to narrowing of this whole thing. Will lead to narrowing of this whole thing, and this is known as infundibular stenosis. This is known as infundibular stenosis. Infundibular stenosis. Now, what happens if this persists? This part of the calyx is separated. This part of the calyx gets separated and does not pick up any on IVP, does not pick up the contrast. So this is known as phantom calyx. This becomes a phantom calyx. So one of the causes of phantom calyx is genitourinary tuberculosis. This is known as phantom calyx. So what are the findings? First we get fuzzy calyx, then we get some orthotype appearance, it leads to infundibular stenosis, and finally we get phantom calyx. Let us move ahead. The CT scan may show the CT scan may show calcifications. It may show calcifications, and even the late stage. At the late stage, we might find putty kidney. putty kidney, the kidney becomes fibrosed and appears like a cement. So this is known as a putty kidney or cement kidney, which is a late finding, which is seen in late stage of genitourinary tuberculosis, which is better picked up by the CT scan. So once we know what are the how to diagnose it, what are the clinical manifestations, let us treat this patient. Let us treat this patient. Now, if we talk about the treatment, medical treatment is the first line of therapy. The therapy that is used is intensive phase of 2 months, intensive phase of 2 months, followed by continuous phase of 4 months. Intensive phase of 2 months, followed by continuous phase of 4 months. What do we use in the intensive phase? We use HRZE. We use rifampicin, isoniazid, pyrazinamide, and ethambutol. And for the 4 months, we use only two drugs, H and R, that is isoniazid and rifampicin. These are the two drugs which are used for 4 months. Now, what happens if the patient is having multi-drug resistant tuberculosis, that is, the patient is having resistant to isoniazid and rifampicin, both the drugs resistant, then we use another regimen which is known as EECOPK. EECOPK is the drug which is used. What does EECOPK stand for? E stands for ethionamide. This stands for ethambutol. This stands for cycloserine. This stands for ofloxacin. This stands for pyrazinamide. And this stands for kanamycin. This is what is given in the intensive phase. We give this in the intensive phase for this. All these drugs are given in the intensive phase for 9 months. 9 months, and only EECO are given in the continuous phase for 12 months. That is a treatment for medical treatment for genitourinary tuberculosis. Let us talk about the surgical treatments. Now, surgery is indicated when the kidneys become non-functional, as in putty kidney. Surgery is indicated when the kidneys become non-functional for the kidneys, and for bladder, if the bladder capacity becomes less, we can go for bladder augmentation surgeries. So basically, when the kidneys become non-functional, as in putty kidney, in these patients, we can go for partial nephrectomy or even total nephrectomy as per requirement. Partial or total nephrectomy. In case of bladder, if the bladder volume is less than 100 ml, if the bladder capacity becomes less than 100 ml, we go for augmentation cystoplasty. What we go for is known as augmentation cystoplasty. Augmentation cystoplasty, where we increase the volume of the bladder by using intestines and all. But if the bladder volume is less than 20 ml, this condition is known as thimble bladder. When the capacity of the bladder is less than 20 ml, it is known as thimble bladder. In this case, we have to go for reconstruction of the bladder. We have to go for orthotopic bladder reconstruction. Orthotopic reconstruction of the bladder, also known as substitution cystoplasty. Very important. Augmentation cystoplasty when the bladder is less than 100 ml in capacity. When it is less than 20 ml, we have to go for reconstruction using that is orthotopic or substitution cystoplasty. In case of ureteric stricture, we can go for stenting. In case of ureteric strictures, for ureter, we can go for stenting. Few other things to remember: if there is a pregnant lady with genitourinary tuberculosis, we usually don't give pyrazinamide. Pyrazinamide is not given; it's contraindicated. All right. Second, if there is a transplant recipient, then in those patients, we usually try to avoid rifampicin, because rifampicin is an enzyme inducer. So the immunosuppressive drugs, they reduce in the plasma. So we don't try to avoid rifampicin. So that's all about the genitourinary tuberculosis. If we get a short note on genitourinary tuberculosis, what are the points we are going to write on? We are going to write about the introduction. We are going to talk about the routes of spread of infection. We are going to talk about the clinical features. We are going to talk about the manifestations in the different organ. How does it manifest in the different organs? In the urinary system, what are the manifestations? In the genital system, what are the manifestation? Which is the most common, which is the second most common, we already know. Then we are going to talk about the diagnosis and how do we support the diagnosis, how do we confirm the diagnosis, and then we talk about the treatment. In the treatment, we have already discussed about the medical and surgical treatment options. That's all about the genitourinary tuberculosis. Please drop your feedback in the comment section and stay tuned to this channel for further updates on general surgery lecture series. Thank you so much for watching.